Good afternoon. I really want to take a moment to thank members of the press for what we at PAHO believe on a whole has been an extraordinary effort on your part for reporting responsibly on this crisis. The public must be kept informed with the best available science and information that we have at hand. You have been patient with our messages on what we know and what we don't know. You recognize the need for vigilance. The biggest mistake we could make is complacency, not overreaction. You recognize we are charting new waters, while at the same time drinking from a fire hydrant of evolving information and science. At times we need to stop and reflect on that new information and question the assumptions we're making in dealing with this crisis. A great example of this was the report last week put forward by a reputable scientist. He claimed, based on the research of the viral genome, that the origin of this H1N1 virus causing the outbreak was a laboratory. You stood by patiently and let WHO and its collaborating partners do their job to provide an interpretation and a more complete, definitive explanation. The outcome was excellent. It took a few days of working around the clock, but the information was analyzed by the global team of scientists, and it indicated that the H1N1 virus we're currently experiencing is a natural virus. So I wanted to say that up front, and thank you again. We know this is a new virus, and to state the obvious, this means we've never experienced it before. Therefore, by that very fact, particularly in lieu of its rapid spread and complications, we know this situation is serious, but we just don't know how serious. Influenza A H1N1 is very contagious, and we fully expect it to spread to new countries, and within countries where it already exists, to spread further. As the Director General of WHO, Dr. Margaret Chan, stated today, this is a subtle, sneaky virus that does not produce a sudden explosion of patients requiring hospitalizations when it arrives in a new country. We don't expect there to be a sudden dramatic leap in severe illnesses or deaths. It seems each week, though, that passes, we have, to some degree, more resolution and clarity on the issues and the remaining gaps in knowledge to best control this outbreak. This week we are learning that approximately a third of people 60 years of age or older may have some protective immunity against this novel strain of H1N1. These people most likely have had some previous exposure, a natural infection or vaccination, to an influenza A H1N1 virus in the past that was similar to the current strain that we're now experiencing. This is excellent news. It also helps, in part, put into perspective why a greater proportion of cases are young adults. But we still are not there yet in terms of knowing all the answers. We have gaps in knowledge about risk groups in particular and severity. Studies are ongoing to fill these gaps of knowledge. H1N1 will encounter opportunities to intermingle and exchange genetic material with other influenza viruses circulating during the winter season in the southern hemisphere. In so doing, this virus is going to challenge our capacity and ability to monitor and understand those changes. People need to know the risk. Usually, that means, with the available information, we need to describe that risk relative to something or event so that people have something to put what they are seeing into perspective. We label the current H1N1 situation relatively mild. The question becomes, mild to what? Last week we said the evidence appeared to suggest that this outbreak is as serious as the 1957 pandemic. This, quote, mild pandemic of 1957 probably killed, at a minimum, 4 times more people globally than the seasonal influenza outbreaks we've experienced in recent years. Obviously, no one wants to create panic, but our point is that even seasonal influenza should be taken seriously, because 250,000 people per year die, and most of these deaths are in developing countries and other vulnerable populations. Some anxiety has been created around this disease, whether this disease is a pandemic, and whether WHO will sound the phase 6 alarm. To be honest, that action, which is likely to happen at some point in time, would mean little to what we are currently doing in the Americas. Countries are already implementing their emergency response plans, which is the hallmark of phase 6. PAHO is working to provide countries with available medications, laboratory support, and when available, vaccines. PAHO encourages all people at risk to be vaccinated with seasonal influenza vaccine as soon as possible. This is a top priority. If we go to phase 6, we call upon you, the members of the press, and all civil society to let your actions be guided by reason. Go about your work with serious calm, concern, and commitment to doing the right thing. Remember that the world is much better off and better prepared to deal with the pandemic, mild or otherwise, than we were 5 years ago. One of the key issues that will arise is the need to ensure that the necessary supplies reach the most vulnerable communities, the most vulnerable countries. This issue requires vigilance both by the press and by the international community. We call upon everyone to continue to remain focused on what our job should be, protecting ourselves, our families, while supporting good governance to strengthen as rapidly as possible the capacity to respond to new cases in the countries of the South. If the H1N1 outbreak fizzles out, great. But if the alternative happens, let's not fail because we were ill prepared or not diligent. So thank you. I'll stop there to entertain any questions.
Okay, let's start with people in the room. If anyone has any questions, Eileen or the lady from Mexico.
I just have a quick question on reporting. A number of countries, and I won't name specific ones, but let's say country A has no reported cases. Country B has a traveler that's visited country A, and that's the only place that traveler has been, and now reports its first case in that individual that traveled to country A. How are we, looking at country A if it's not reporting any cases? What are you doing to verify what's actually happening in that particular country?
That's a great question. And it's a question we often discuss about with our students in taking surveillance classes in public health. If a country is not reporting cases, one of two things may be happening. One is that surveillance is not sensitive enough to detect cases, and there may be transmission. So that is of a concern. Or in the other situation, surveillance is quite sensitive, high quality, but there's no virus circulating, and the surveillance documents that. I believe that that's probably happening in both situations to some degrees in certain countries. To that end, PAHO has sent teams of experts from CDC, Atlanta, Public Health Canada, as well as experts from WHO and our own staff to Central America, where the virus has been traveling south, to support surveillance activities. There's also been the distribution of laboratory reagents that would also help with the diagnosis. Laboratory capacity has been a concern in the past, and I think over the last 5 years there's been a lot of work going into that area, and again, I think we're just so much more prepared compared to 5 years ago. But an excellent question, and I think that's the approach we're taking.
Yeah, a similar question is, there was an article in the New Scientist on the 20th of May addressing the fact that the way Europe was deciding or not deciding to test individuals used a very rigorous case definition, and that case definition required that the person had traveled to a North American country or had been in contact within 7 days to someone with a diagnosed H1N1. Do you think they're missing cases? Do you think they're missing within the country person-to-person transmission?
I think given what you described as the case definition, most definitely there will be missing cases. I think as I mentioned in the presentation, it seems like every week we accumulate more knowledge that gives us a better understanding about what's happening. And when I recall back 4 weeks ago when we were studying the data coming out of Mexico, we realized that the initial approach was to look for cases in hospitals. And so that really can bias your understanding of the outbreak. And then over time, it was fairly quickly over time, it was recognized that that approach needed to be expanded. And oftentimes we use the term throw the net out wider to capture more cases and then give you a better understanding of transmission. So that definition that you described is very limited in terms of trying to have a sensitive case definition. We know the virus can live outside a living organism for a few hours. So imagine the situation where even if a traveler comes from an infected country but goes to a theater, goes to a marketplace, and happens to cough on their hand while they touch the doorknob of a door at a large public event or theater, someone could be participating in that event and not know that they had connection to a traveler, and so thereby you would be missing several cases and missing the understanding of what's causing transmission.
Okay, thanks, Dr. Andrus. We have a question from a journalist in Ecuador, Carla Pesantes from El Telégrafo. She notes that Ecuador reported its first positive case of AH1N1 on Friday, the 15th of May. And 3 days later, there were 7 new cases reported. The first case was a minor, and 4 of the new cases have also been minors. Authorities informed that the first minor was infected during a trip to Miami, and they have the same suspicion about the other minors. Can we then affirm, as our local health authorities say, that the virus has been imported, or the virus was imported, and that it is not circulating in this country?
I think given the information, the answer is yes, that it is most likely an imported virus that previously was not circulating, but it does raise the question of how sensitive surveillance was before and those issues we just were discussing. But that's most likely the scenario.
Okay. And then we have a question from Abida Alaham in Trinidad via Illuminate, and she asks a very straightforward question. With the virus appearing to slow down, can people feel safe to travel now?
I think the best response to that is common sense recognition that if we know the virus is still circulating, that there's always a risk. So those important public health measures about protecting yourself and your family certainly apply here. The covering of sneezes and coughs with disposable tissue, the frequent hand washing, and social distancing are very, very important.
Okay, great. And then we have a question on the phone from the Associated Press. Caller, if you can go ahead with your question.
Is the novel swine flu virus more infectious than the seasonal flu?
Could you repeat that?
Sure. Is the novel swine flu virus more infectious than the seasonal flu?
That's a great question. It's currently being studied. The preliminary analysis of the data coming out of Mexico seemed to show that it was more infectious. There's ongoing work to confirm that. I think that what we see in terms of the evolution of the outbreak is that when it enters a country, it doesn't begin in an explosive fashion, but cases accumulate over time, and we see a definite outbreak distribution. And it seems that with the available evidence that is occurring more rapidly, but we're continuing to study that and confirm the initial studies that were conducted in Mexico about the infectiousness.
Okay, thanks, Dr. Andrus.
Can I answer?
Yeah, I'm sorry. Go ahead, AP. You can follow up.
Thank you. The second question, we've seen numbers regarding surveillance in humans. How about pigs? How many samples have been taken from pigs in different countries?
That's a very good question. I do not have those data, but I can find out for you. If you leave your information, we'll get back to you. I know there's ongoing. I know there's ongoing work, but I don't know the definite numbers.
Okay, if you send us your contact information, we'll try to find out for you and get back on surveillance of pigs. Now we have a question from the Hispanic Link News Service, Julio Zaneta, who asks, what resources are out there in Spanish from PAHO to disseminate information about avoiding this disease, and how can Hispanics in the U.S. access it? That's pretty straightforward, isn't it?
Yeah, there's a huge volume of information on PAHO's web, WHO's web, in several languages, including Spanish.
And I think the CDC has quite a bit of influenza information on its page, and in Spanish as well. The link is on the front page of the PAHO web. Okay, and then we have a question from Carlos Uriarte Mora in San Miguel, who says, should we be making a call to public enterprises and private businesses for them to put on their web and on things like water and light bills, telephone bills, orientations on influenza or gripe, as well as on buses and interurban transport and flights, with posters and information about how to prevent influenza?
It's a good question, and I believe there's a great deal of work being done. It will vary by community and location and country, but it's very critical to keep the public informed about the necessary actions to protect their families. And I think you see this in the press, as I acknowledged, and in certain community places. I saw on my own bus going home the other evening posters. So it'll vary, but it is very, very important to do all that can be done in that area.
Dr. Andrus. We have another question from Ecuador with respect to vaccines, in which she says, do we still have the same information that we only have the capacity to produce between 1 and 2 billion vaccines against AH1N1, and that countries will have to plan its distribution and application? Or do we have a better idea of how many vaccines we would need and whether we would have enough for global distribution? And when would we expect vaccines to be available?
Very good question. I'll start with the second part. Well, our best estimate for when vaccines will become available will be 4 to 6 months. The calculations that go into the expected supply were made and a few weeks ago discussed in what is called a Global Task Force on Vaccine that is conducted by WHO Geneva with our office and several other WHO offices around the world. The beginning, the estimates were 1 to 2 billion doses that were based on information from a variety of manufacturers, probably more than some 24 manufacturers. Surveys have subsequently been conducted that Dr. Marie-Paula Kinney reported on last week in the WHO proceedings, and so we have better estimates. I think I'll just go to the bottom line. We know that the supply will not be sufficient to vaccinate all 6.7 billion people that live on the planet. Supplies and supply estimates will vary, but some proportion of that population will be vaccinated, and the best strategy will be to target those folks that are most vulnerable. Those vulnerable people we know are the very old, the very young, pregnant women, and people with chronic medical conditions. So I think with that strategy, and also keeping in mind the need to ensure equity and access to the vaccine, that we will be prepared and ready to distribute the vaccine using the best strategies. There will always be questions about supply, but I think we're working very hard to ensure the best plan of action is developed and implemented in the time remaining before a vaccine will become available. Having said that, though, there needs to be a careful calculation of risk and benefit to proceeding with a full-scale recommendation for vaccine manufacturing, because it will have consequences on the availability of the routine seasonal vaccination. So with that in mind, we should have a very good understanding that the disease burden, and more importantly, that the deaths caused by this new virus outweigh or are more than the deaths caused by seasonal virus, for example, and other important factors related to disease burden, that's well understood and is factored into any decision. And finally, the decision should be flexible. So again, the most vulnerable populations have been targeted, and we know there are resources to help them.
Okay. And then we have another question asking, do we have any idea really how much this vaccine would cost? Or I guess we could base it on how much a normal seasonal influenza vaccine costs.
Right now, the price varies by country, but I could say that it ranges $2–3 per dose of vaccine. And with seasonal vaccine, because we make it yearly, and the people have been exposed to viruses on a yearly basis, one dose strategy generally is enough to have a very good protective effect in the population. But with this new vaccine, there are questions regarding the number of doses, and most likely the last discussion that we had in this global vaccine expert meeting is that it most likely will require 2 doses.
And then Don Ellis asks, staying on the vaccine subject, what regions will have priority access to the vaccine?
That we are currently working on. What I know is that of the 24 or so manufacturers that responded to the questionnaire put forward by WHO Geneva, 6 or 7 of them are the major manufacturers that count for the great proportion of doses that will be produced. Probably at least 80% of the supply that will be produced. And we do know that of those large suppliers, some of them have what are called pre-production contracts. So that, for those of us that are working hard to ensure this vaccine is available to everyone, that is of concern, and that was mentioned in a meeting just a few days ago convened by the Secretary General of the United Nations and the Director General of WHO, highlighting the importance of making the vaccine accessible.
Okay, thanks, Dr. Andrus. I think we have one final question from Connie Ralph, a public health emergency planner in Maryland, who asks, has any consideration been given to the inexpensive and non-harmful homeopathic medicinal remedies for the treatment of influenza? There's evidence to suggest its efficacy during the 1918 influenza pandemic. Although major drug manufacturers would not benefit financially, the treatments are widely available and production could be increased.
Unfortunately, I don't have any information on that. We can do our best to try to locate any studies or information, but at the moment I'm not aware of any information. Dan, before we close, I wanted to have one point of clarification on the question coming from AP about surveillance. When I responded, surveillance in public health is an ongoing activity, and there may be special studies, but I'm not sure about whether or not there's just ongoing surveillance among pigs for this virus. I'd rather doubt it. But there may be special studies targeted and focused in certain conditions or certain locations. So just a point of clarification, and we will get back to him to see what information is available.